Guzman.
Yes. Yeah, at the onset, I would like to thank Dr. Kumar for invitation to be part of his course. So this course has certain challenging situations, so I thought that I will choose probably two slightly gray zone areas. So this is one, I think I would like the panel to actually give opinion on this first. This is a 67-year-old male patient, had undergone cataract with IOL implantation about 5 years ago, and had decentered rigid IOL. As you can see, it's bisecting the pupil, the vision is compromised. The fundus evaluation and intraocular pressure is normal, and the capsular support is barely 20%. It's not really very stable lens. So what would you like to do in this situation? Would you like to leave him alone? You would like to do IOL exchange with iris claw lens? Would you like to do the SF IOLs, either with suture, glued, or Yemenis, or something else? Is there anybody from the panel who would like to chip in to tell what they would like to do in this case?
I think the first thing to do is to see how much of the anterior capsule support is there.
Not much.
Yeah, if there is not much of an anterior capsule support, then it's wiser to, if it's a three-piece, you can go ahead and do a Yamanis and fix, or the glued IOL and fix the same lens.
It's a rigid IOL, no?
It's
Yes.
a rigid, but three-piece.
It's a rigid
na?
lens. It's a rigid lens.
It's a rigid, it's not
Yes.
three-piece, yeah. So then you explant it and then go ahead and do a secondary IOL.
Okay, so you would explant it and do a secondary IOL. Anybody else? Dr. Harshul, would you like to? Or Dr. Mohan Rajan, sir? It's a rigid lens which is displaced.
I'm sorry.
It's a rigid lens which is displaced, and it's bisecting the pupil. And there is not much capsular support. So what would you like to do in this scenario?
So I would probably, just do a, what kind of a lens is it? Is it like what are the
It's a
haptics?
rigid PMMA.
I know it's rigid, but what are the haptics? It's a single piece PMMA lens,
Single
is
piece PMMA
it?
lens.
Okay. Yeah, so you could technically do a scleral fixation with sutures, because if you extrude this haptic, it may not be the ideal lens for that. But I would probably recenter. What's the status of the the capsular support in the periphery? No rim.
No, not much.
Okay. Yeah. So I would probably anchor it to the sclera. Yes.
I will explant the lens and put a glued IOL in this patient.
You can even suture it to the iris, actually.
Right, exactly. So I think of all the options, because it's a rigid lens, we can't actually do the scleral fixation. And if we have to do any of the other secondary IOL implantation, then definitely we will have to first explant IOL. So it requires a big incision, then implanting the lens of your choice, and then doing the procedure, putting the sutures back in. So we discuss if it is possible to maintain the same lens. The only possibility, as Dr. Gaurav said, is that if it is possible to stick the lens to the iris by doing what is called as a iris claw lens.
And how's the
iris sutured lens?
how's the endothelial cell count, specular count in there?
It's good. Yeah, it's like everything else is very good actually. The fundus is good, intraocular pressure is fine. So because we have to do a iris fixated lens, it's important that we don't get the haptics out, because we want the haptics to be there behind the iris, and we just have to get the optic out. So because of the lack of time, I'm just going to run. So once the optic is out, and it is like a capture of the optic above the pupil, and after that you can use a Prolene 9010 suture with a curved needle, and then you can go through the cornea in the periphery, go to the iris just behind the haptic optic junction, go out of the iris, and then come out of the cornea from the other side. And then that's how you create the loops, and once they are created, you can go to the other side, and then of course you take them out by the typical McCannell sutures, and then you can suture it back in its place, and the iris sutured lens is pretty stable after that. So this is a way in which you don't have to really explant the lens, and in terms of the rigid lens also you can do it. So the second case is a post-RK patient. So basically, as you can see, the patient had about grade 2 cataract. This is the pentacam analysis that we can see, and you can see it's a very flat cornea, about 30 to 31 diopters. This is the other eye. And when we did the biometry on both IOL Master and on the ASCRS, these were the calculations. So what kind of lens would you prefer? Like what will be the dioptric like entity of your choice? How will you choose?
Go to the ACRS, whether it's a 8-cut RK or a 24-cut RK, you have the website and just see the information and then correlate it with your Lenstar or your IOL Master, and that will get a good idea.
So like in this case, if we go for the ASCRS calculation, which is below,
Where's
we,
Barrett's,
we are
True
going
K?
between 17 to 19 diopters.
Where is Barrett's True K? I trust Barrett's True K a lot.
Yeah.
Yes. So I think
But
the
I think,
Barrett's-
I would have
yeah.
used something like an 18 on this.
You would
I would
like
have used an 18 diopter.
18 diopters lens. Okay, sure.
Sorry, I
so
would have used
let's
the
say that-
highest is 19. I would use 19. I'll choose the highest power which all the
Slightly
formulas
on
are
the
predicting.
myopic side. And what if, because this is a relatively, let's say, more straightforward case in which there are 8 to 12 incisions, but if there are more incisions, like 32 incisions and very badly scarred corneas, and you get a very variable IOL master, or even on ASCRS, ranging between 15 to 20, 21 diopters, then in that case, how will you choose?
I would take my cursor on the screen of the topography screen and find this flattest K that I can find and use that in my formula.
All right. Anything else? Anything, any other point that anybody wants to chip in?
I will also do the same thing, flattest K.
Flattest case.
Yeah.
Dr. Arshinov, if there is
I
anything
think you
else?
should consider how old the patient is, because what happens, they keep getting progressively hyperopic. And so
Yeah.
I tend to aim for someone who's younger to be -2 or -2.5 until they're going to get worse otherwise, and they're happier that way.
That's true. But if it is ranging between 15 diopters to 20, 21 diopters, such a big range, so how will you choose? So, okay, so in this case, what we have tried to do is basically we did not rely on both ASCRS as well as on the IOL master. What we did was we removed the nucleus and we did what is known as the intraoperative retinoscopy. Because the intraoperative retinoscopy readings are not going to vary too much. And when you get that, you have what is called as a Maloney's formula. With Maloney's formula, if you, for example, in this case, we got 11.50 diopters of retinoscopy value, then you have to multiply that by about 1.7 times more, so which becomes 19.55, and we would like to go slightly myopic side, so we went for 20 diopter lens in this case, and from almost -10 diopters with -2, which was a preoperative refraction, it brought it down to almost negligible spherical refractive errors. Actually, the studies have shown that even with the best formulas that we have just discussed, 25% of the patients who have had RK are still out of bound more than 2 diopters of post-operative surprise. And the 26 cases that we have done with this two-step retinoscopy method, I think 100% of them have been within the ±1.5 diopters of the
Vardhaman, what was the
prediction
power of the lens that you eventually used in that case?
20 diopters. Pretty close to what you have said, yeah. Okay, thank you so much for your kind attention. Thank you.
Beautiful.